You know how that's going to be? Maybe, maybe not. It's the first branch is one thing I can tell you. It could be a little bit before it, could be a little bit after it. It's just really variable. And I hate to tell people it's going to be at a specific spot because, as y'all have seen, if anything through this course, blood supply is so variable. I hate to tell you that. I can confidently tell you it'll be the first branch coming off of it. Yes?
Can you say again the branch of the lingual artery, please?
Dorsal lingual.
That's your first one?
Yes, ma'am. And then it splits into two terminal branches, deep lingual and sublingual. I think the only reason I put this on here is to make sure everybody understands it's all muscles of the tongue are cranial nerve 12 except for palatal. So both intrinsic and extrinsic muscles are cranial nerve 12 except for palatal. Okay. Definitely know innervation of the tongue. We talked about motor, so we're going to make sure you know sensory as well. You know that the anterior 2/3 of the tongue is general sensory from the lingual nerve, from B3, from trigeminal, in case anybody didn't know that. Chorda tympani from the facial nerve is special sensory taste to the anterior 2/3 of the tongue. The posterior third of the tongue, most of it is cranial nerve 9 for both special sensory and general sensory. And then the very most posterior part of the tongue and the epiglottic region is going to be by cranial nerve 10. And for those of you who may have read something there, the internal laryngeal is getting that part, because remember it's getting sensory to the supraglottic cavity. Well, epiglottis is part of the supraglottic, so it makes sense why it's that as well. Now, part of the reason I want to stress about this, or not stress, but talk about this as well, is thinking about these things relative to, let's say, lesions at foramen. I think you'll see a fair amount of things. We expect you to know. If you don't know yet what nerves travel through what openings, now would be a good time to learn those things. So it's a case of, if you had a lesion at the petrotympanic fissure, everybody should know by this point that you're going to lose taste of the anterior 2/3 of the tongue. General sensory would still be fine at the petrotympanic fissure because lingual nerve is not affected. So it's getting to know what goes through different openings and what they contain or whatever. So if, a patient came into your office with diminished taste from the posterior third of the tongue, I'll immediately know, oh, that's a cranial nerve 9 thing. Where might a lesion occur because of that? Yes, sir?
Does 10 do taste too, or is it just sensation?
10 is taste and sensation. Both of them. Good question. Okay? This should be simple and straightforward, but make sure you learn that one part I talked about lymphatic drainage from the tongue, how the tip of the tongue will drain down to the submental node, anterolateral is going to submandibular, anteromedial is going down to the inferior deep, posterior part of the tongue is going to the superior deep. Okay, so know that thing in there about that lymphatic drainage of the tongue. Very good. Why is that picture of the guy on here? Oh, yeah. Like, what the? Yeah, I remember now. Okay. Obviously, if it's something related to trigeminal, make sure you know. Okay? We have stressed and talked multiple times about sensory innervation versus facial innervation. So I'm particularly thinking review type stuff or whatever. You know there's going to be something on there, making sure you understand the difference between sensory innervation to something on the face versus a facial nerve thing. So make sure you get this kind of distribution. We talked about like a nasal cavity, some areas where we kind of got a little bit more about like V1 distribution, like down the root of the nose versus bridge of the nose, like external nasal coming off anterior ethmoidal, that kind of thing. So have this sort of an understanding of distribution versus, that. But also, Dr. Hinton talked about different areas like nasal cavity. So anything that's got that trigeminal hook to it, we're going to be stressing and make you know about. So make sure we're just talking about innervations to certain parts of the nasal cavity, palate, pharynx, all this new stuff. Anything we gave you sensory for any of the new materials, no. Okay? I'm saying it's difficult. I'm just saying just make sure you know. I don't think it's difficult. You'll know it. That was just my way. No. Okay. Let me talk a little bit about several things relative to this. Our good friend, the pterygopalatine ganglion. Okay. First off, what's happening inside the ganglion? First off, let me back up from that. It's a ganglion. What is a ganglion? A collection of neuronal cell bodies outside the central nervous system. This is old hat. This should not be anything new, but I'm just trying to make sure everybody understands. So there are two types of ganglia you need to worry about. Parasympathetic ganglia, sensory ganglia. And neither the twain shall meet. Okay? If I'm a parasympathetic ganglia, the only cell bodies that will reside inside that parasympathetic ganglia will be parasympathetic neurons. No sensory neurons, no motor neurons. I'm talking general motor, not parasympathetic motor. Okay? Will other fibers or axons travel through that ganglion? You betcha. It's going to have sensory going through it. It's going to have sympathetic going through it. All right? All kinds of stuff can travel through it. So let's, first off, for the pterygopalatine ganglion, it has a nerve coming to it that is the nerve of the pterygoid canal. So here's the sphenoid bone, nerve of the pterygoid canal going through the sphenoid bone. You know that it's the nerve of the pterygoid canal is formed by two nerves. Greater petrosal, containing preganglionic parasympathetics, and deep petrosal, containing postganglionic sympathetics. Nerve of the pterygoid canal. All these axons come here. The preganglionic parasympathetics of greater petrosal, a branch of the facial nerve, will synapse in the pterygopalatine ganglion. And then postganglionic parasympathetics, along with the postganglionic sympathetics that we're traveling through, some sensory nerves coming off V2, whatever, will go from the ganglion to go out to different places. All right. The autonomics are going to go to what? They're going to go to nasal glands. They'll go down to palatal glands. They'll go to pharyngeal glands. They're going to show in a minute go off to the lacrimal gland for parasympathetics or whatever. Okay, they'll go to all kinds of different glands. All right. Here's V2. V2 gives off multiple branches, and you know if it's a branch of V2, it must be what type of nerve? A sensory nerve branch, because that's all V2 is. So you'll see right here coming off, here are my greater and lesser petrosal nerves. It's greater and lesser petrosal, that's good, Robert. Greater and lesser palatine nerves, pardon me. Coming off, the axon's traveling right through the pterygopalatine ganglion, headed down here towards hard palate, soft palate. All right? There's also some branches that will come off from V2 that will come over as the lateral nasal nerves, going over to the lateral aspect of the nasal cavity. Yes, ma'am?
So are those direct branches of V2?
They are direct branches of V2.
Even if they go through the ganglia?
They are direct branches of V2. They're going to, whatever pathway they got to know. They got to go, they're going to go there.
Do the lateral nasal travel through what foramen?
The lateral nasal don't go into anything you're going to even worry about.
Okay.
Okay? Just same thing with the greater and lesser palatine. You don't have to know how they're getting to the ganglion, what they go through, just know they're going through. Yes, ma'am?
I think in Netters it also says that there are lateral nasal branches of the anterior ethmoidal.
I'm not going to say that's not true, but let's don't worry about it. If there's not anything we haven't taught you about, don't worry about it. Yes?
Maybe you just answer his question. Were you saying like from V2 to the ganglion? Like there's nothing that we need to worry about that goes, but
For those nerves that I just mentioned. I didn't say anything about relative to nasopalatine and going through the sphenopalatine foramen or whatever. I'm saying for those two, the palatine nerves and the nasal, these lateral nasal nerves, you need to know how they travel to get into this area. Okay?
But all three of those go through the ganglion or not the lateral nasal?
Honest to goodness, it's not really even important.
Okay.
Okay, I understand why you're asking, but I'm just saying it's not going to be important. Yes, ma'am?
For lab, will you tag nasopalatine coming out of incisive foramen?
I understand. I don't think you would see nasopalatine nerve whatsoever. Maybe somebody tags the incisive foramen on a skull and says what structures travel through this bony opening. And that's where I would know relative to nasopalatine. Or I would also know nasopalatine going through the sphenoethmoidal foramen on a potential test question. Yes, sir?
How would you tag the zygomatic nerve?
How would I tag the zygomatic nerve? Hang on, I'll get there. Ask everybody else in here, they're going to tell you the answer to that. How would I tag the zygomatic nerve?
Lateral.
Going laterally from V2. Whoa!
What did you just say, the sphenoethmoidal?
That's what I was thinking.
Sorry. Spear said it again.
Doesn't